Thank you for having me today, and thank you for inviting me back. And good afternoon for those folks on the West Coast, and good evening if you're closer to where I am here on the East Coast. Today, I'm going to be presenting on behalf of my team at Hopkins and talking about a mixed methods research study that we did looking at factors influencing breast cancer screening and follow-up care specifically for Black sexual minority women. And I want to begin by just showing you the faces of the folks that I work with. So the lab that I was a part of when I did this work is led by Dr. Lori Dean, who you can see on the upper left-hand part of the screen. And this work was really driven by Drs. Lori Dean, and next to her, Dr. Tonya Petit, who is now at the University of North Carolina, Chapel Hill. We also worked with a fairly long-standing nonprofit organization and community-based organization, Zami Nobla, and you'll see Marianne Adams, who's right next to Dr. Petit. And on the left-hand side of your screen, you'll see my colleague, Dr. Christy Treadway, and on the bottom, Dr. Joanna Malone and Sophia Geffen. So we all work together to make this work possible, and I'll be sharing a lot of what they've actually produced through this presentation. I'll begin with a little bit of background around breast cancer and what we know about breast cancer in a couple of different populations. So from the literature, we know that Black women are diagnosed at later stages of breast cancer, and that's primarily due to there being longer times between mammograms. There's been some recent data that's come out from the American Cancer Society suggesting that the disparities that we used to see in screenings may actually be closing between Black women and other racial ethnic groups of women, but there still seem to be delays in care after having an abnormal result. And so at least one study that we found during our research showed that Black women have about a 1.39-fold odds of a 2-month delay in breast cancer after abnormal mammogram. Also in the literature, there's not a lot, as we heard from the previous speaker, about the health of sexual minority women. So again, women who identify as lesbian, bisexual, queer, gay, same-gender loving. But there's some indication that sexual minority women may have a higher risk of breast cancer compared to heterosexual women. And some of this may be about lower rates of screening, but also higher rates of things like alcohol use, which are associated with breast cancer. What we don't know and what's not very clear in the literature is what happens when you're at the intersection of being a Black woman as well as a sexual minority woman. And intersectionality is a social theory that posits that when you live at the intersection of various marginalized social identities, that could have an impact on your health because those identities represent the intersection of various social locations, particularly marginalized social locations. And so with that gap in the literature in mind, we sought to try to understand breast cancer screening and follow-up care, specifically among Black sexual minority women. And we started by looking specifically in the literature to see what was already there. And this was work led by my colleague, Joanna Malone, who did a scoping review trying to find out what breast cancer screening and follow-up care looks like specifically among Black sexual minority women. So she, as well as our other colleagues, looked at literature from 1990 through 2017. And what we found was a little bit troubling. There were very few studies looking at breast cancer screening or any sort of follow-up care that specifically included Black sexual minority women. And in fact, one of the largest studies, which is the Nurses Health Study 2, which includes about 36,000 participants. Of those 36,000 participants, only 1.5% were Black women. And women, I don't believe, were either not asked about their sexual orientation or at the very least were not separated out by their sexual orientation. And so it's very unclear what breast cancer screening and follow-up care looks like specifically for Black sexual minority women. And so with that, we decided to embark on a mixed method study to try to answer some of these questions. So our mixed method study had an exploratory sequential design approach where we started with qualitative interviews with about 15 women who identify as Black, cisgender, sexual minority women. Sexual minority could mean that they identified as gay, lesbian, queer, bisexual, same gender loving, or some other identity that was not necessarily straight. We sampled women from across the country, and we asked them questions focused on their experiences after receiving an abnormal mammogram specifically, or after breast cancer. And we also asked a lot of questions around their experiences within the healthcare system, particularly living at the intersection of being a Black sexual minority cisgender woman. From our qualitative study, we then moved on to do a larger quantitative survey that was informed by our qualitative research. This went out to about 729 cisgender women of different racial ethnic groups, again, over the ages of 35. This was a national survey that we did online, and we expanded our definition of abnormal screening to not just include a mammogram, but also things like an MRI, ultrasound, or clinical breast exam. And we asked participants specifically about 3-month delays in care, among other things, after having some sort of abnormal screen or having a breast cancer diagnosis. And so I'll share a little bit about what came out of those studies, but essentially what we did was to interpret our quantitative data, we compared across these intercategorical groups that you see here. So we compared the experiences of Black versus non-Black, sexual minority versus non-sexual minority, cisgender women. So we compared Black sexual minority women, white sexual minority women, Black non-sexual minority women, and white non-sexual minority women. And it's really important, not just to mention all of my colleagues that were involved in this work, but this work would have not been possible without the myriad collaborations that we were able to make to recruit the women who were part of our study, including the Pride Study, as well as Army of Women, the Erica Hart Foundation, Living Beyond Breast Cancer, the National Institutes of Health, and the National LGBT Cancer Network. So I'll begin by sharing the results of our qualitative research, or the qualitative arm of our research. And I'll actually begin by introducing you to one of the theories that really grounded this research, and that's self-determination theory. One of the reasons why we picked this theory is that it's a theory of motivation, specifically what motivates people to do behaviors that aren't necessarily intrinsically motivated, like going to get breast cancer screenings. Many of us aren't actually intrinsically motivated to want to go to the doctor until we absolutely have to. So this theory posed by Ryan and Decci gets at what leads people to do something if it's not something that they very internally want to do. And there's 3 constructs that are a part of this theory, and they are autonomy, competence, and relatedness. And so when these constructs are supported, people are then motivated to do many of the things, specifically in healthcare, that we want them to do, but that they might not be intrinsically desiring to do. Autonomy is defined as the feeling of being the origin of one's own behavior. Competence is the belief that one can achieve a particular outcome. This is sometimes referred to in the public health literature as self-efficacy. And relatedness is that need to feel connection and belongingness with others. And as I said, when these three constructs are supported, people tend to then be motivated to do the things that they wouldn't necessarily be intrinsically motivated to do. Our research, our qualitative arm of our research was guided by this very broad open question. So we really just wanted to understand the nature of healthcare provider interactions, and really any interactions within the healthcare system for breast cancer screening and care among Black sexual minority women. And here is, in a nutshell, what we found. So generally speaking, participants talked to us about their positive experiences that they had within the healthcare system during the sort of um, breast cancer screening, treatment, and follow-up care, and then negative experiences that they had. And essentially what we found is that when there were healthcare providers and healthcare systems that supported their autonomy, the participants' competence, and their relatedness, that all led to more positive interactions throughout this process. So for example, participants talked about how when a provider respected their choices regarding the treatment that they wanted and the care that they wanted, they expressed that being a more positive experience. So that would be related to feelings of autonomy. Participants talked about being able to find the type of care that fit their needs and when healthcare providers actually help them do that, and that would be related to competence. And then participants also shared with us that they had much more positive experiences with healthcare providers who shared at least one characteristic with them. And it could have been race or gender or sexuality or some combination of these three. But when the healthcare provider shared at least one characteristic with the participant, which falls under the category of relatedness, they also tended to express more positive experiences. On the other hand, when participants talked about negative experiences that they had, either specifically with individual healthcare providers or within the healthcare system, they fell into situations where these three constructs of autonomy, competence, and relatedness were not supported. So, for example, participants described situations where healthcare providers failed to take the participants' view of their own body or the opinions about what kind of care they wanted seriously. Participants describe situations in which the healthcare system, maybe more broadly, or providers failed to help them find the care that they needed, undermining their ability to exercise competence. And then sometimes participants described a lack of support from healthcare providers or the healthcare system, somewhat related to the construct of relatedness. And I want to share with you some of the actual quotes and in terms of stories that participants told us in their own words. So this is a participant describing her ability to exercise autonomy with her provider. And so she says, I did what the doctors, for the most part, wanted in terms of the surgery, doing the tamoxifen and all of that. I knew it was ultimately my decision, but I went with their recommendation. The tamoxifen, like this 10-year thing, I'm not crazy about it. I'm doing it because it's recommended. I know I could stop if I wanted to just because it's my choice, but I still feel like it's primarily my decision to keep taking this, even though I'm not crazy about it. Yeah, I think it's my overall decision. So again, this participant is expressing her ability to exercise autonomy. And again, going back to Ryan and Dechi's framework, she's being able to express autonomy and motivated to do something that she's not crazy about, but she's doing it because she does feel like it's her decision, a decision, even though it's also recommended by her healthcare providers. This is another participant of ours describing this construct of relatedness. And so this participant says, it just so happens that the majority of my doctors are minority women. My radiologist, my breast specialist, my oncologist, my primary care, all women, and they're all minorities. They treated me fairly. They asked about my partner. I mean, and here she's referring to sexual orientation, was just like that was just another piece of information about me that they knew. It didn't make a difference one way or another. And so I think there's actually two things that are being expressed here. Number one, this feeling of relatedness in terms of the fact that this participant shares some characteristics with her provider, but also the fact that her sexual orientation is just another part of who she is. It's not put out in front as a big deal, but it is acknowledged as a part of who she is. And then finally, I want to share a quote in terms of what happens when these constructs of autonomy, competence, and relatedness are actually undermined. And Ryan and Dechi describes this as leading to alienation. And so this is a quote from one of our participants who's describing trying to find a support group for her partner. So the participant was the one who had been diagnosed with breast cancer, and she was looking for a support group for her partner. And she says, I used to ask T, that's her partner, to go with me, so I'm sure they knew I was a lesbian. I even asked for a support group for T, and the healthcare providers told her, well, we don't have that. We have support groups for husbands. And so the participant responds to the healthcare provider saying, but she's not a husband. And so the healthcare provider simply says, well, we don't have that. And so I think in both a very literal way, but also in a very abstract way, this participant was quite literally alienated from getting the type of follow-up care that she needed, not just for herself, but also for her partner. I'll move on and spend a little bit of time talking about the quantitative studies that have so far come out of this research. And there were two major quantitative research questions that we had and that we wanted to answer with these data. So the first was to understand the extent to which Black sexual minority women specifically were likely to experience delays in cancer and how that might be different from other groups of women as defined by their race and their sexual identity. And the second question was to try to understand or learn about the barriers and facilitators that are associated with breast cancer screening and follow-up care. And so for our first research question, we hypothesized that because Black sexual minority women live at this sort of triple intersection of marginalization, that this group would be more likely to experience delays in care compared to other groups in our sample. And for our second research question, we hypothesized that issues like structural factors and stigma would be most greatly associated with delays in care for Black sexual minority women as compared to other groups of women in our sample. So I'll begin by showing you some basic descriptive statistics from our sample. So first, what I'll point out here is the 3-month delay in care. So you'll see that Black sexual minority women were the most likely to report delays in care after an abnormal mammogram or a breast cancer diagnosis. 29% of Black sexual minority women in our sample reported this, compared to 11% of Black heterosexual women, 10% of white sexual minority women, and only 5% of white heterosexual women. And you can also see some of the demographics of our sample. So in general, the women in our sample were about middle age. Black sexual minority women were a little bit younger on average at 49 years of age. Generally speaking, the majority of women in our sample did have a college education, although those proportions are much higher for white heterosexual and white sexual minority women. Black sexual minority and Black heterosexual women were far less likely to have an income greater than $5,000. And I want to skip down a couple of rows and just show you differences in the social support score and stigma score. So in our sample, in our sample, Black sexual minority women were the least likely to report having social support, given the metric that we used for this, and they were also the most likely to report stigma across the 4 groups that we examined. And taking all that together, when we adjust for various individual differences, what we find is that Black sexual minority women were about 5 times as likely as white heterosexual women to delay care after having either an abnormal screening result or having a breast cancer diagnosis. And so you can see there in that second bar in model 3, the odds ratio is 5.17, heavily elevated. Black heterosexual women also had elevated odds of delays in care, although that was not statistically significantly different to the reference group, which was white heterosexual women. And white sexual minority women also had an elevated odds, but again, not statistically significantly different from white heterosexual women. And to answer the second part of our research question, we also asked women in our sample about reasons for delaying care. And there were a number of different reasons that individuals were asked, and then these were grouped under these 5 groupings that you see here: structural reasons, institutional reasons, interpersonal reasons, and minimization. And in terms of what falls into each of these groups, structural reasons for delaying care include things like the cost of care, being able to find transportation to get to care, as well as being able to or not being able to find childcare if you needed to go get care. Institutional reasons included things like an inability to reach a person's healthcare provider. Interpersonal reasons included things like a distrust of the system or a fear of being stigmatized by the healthcare provider. Intrapersonal reasons included feeling that getting follow-up care after a diagnosis or after an abnormal result would be pointless, or that it would be embarrassing, or people didn't want to get care because they didn't want to worry other people. And minimization issues. So feeling that there were other things that were far more important in life, other priorities, or just not believing the result, or not feeling any pain. So not necessarily thinking that it was an issue. And what you can see here in the bars is the prevalence of these different types of reasons for delaying care among the 4 groups that were included in our study. The blue bars represent white heterosexual women. The orange bars represent white sexual minority women. The gray bars represent Black heterosexual women, and the yellow bars represent Black sexual minority women. And in pretty much every one of these groupings of reasons, we see that Black sexual minority women have the highest prevalence of each of these issues for delaying care, with the highest being within these interpersonal reasons. More than 50% of Black sexual minority women delaying care for things like not wanting to worry others or being embarrassed about having a particular diagnosis. And there's lots of ways to include intersectionality in the public health literature. It's really exploded over the past few years, the incorporation of intersectionality as a guiding theory. I think at one point we were only seeing this being done or applied within qualitative work, but more recently there's been a lot of interest in trying to apply intersectionality in a quantitative way. And I think there's lots of different opinions about whether or not that can and should be done and how best to do it. I just want to point out kind of a different way of measuring intersectionality. So what you've seen here is for us to do an intercategorical approach where we're grouping people at the axes at which they live. So grouping people along their race, ethnicity, and sexual identities, and creating these intercategorical groups. There's also some measures that were developed by a colleague of mine, Dr. John Jackson, who's also at Hopkins, trying to apply some different statistical ways of trying to understand sort of the proportion of a disparity that can really be attributable or attributed to living at a particular intersection. And I want to share with you just what that would look like in the data that we collected. So overall in our sample, the disparity between Black sexual minority women and white heterosexual women in delays in care was about 20%. So there's about a 20% difference. I should say there's a 20 percentage point difference between those two groups in the prevalence of delaying care, again, after either an abnormal result or a breast cancer diagnosis. And using these methods developed by Dr. Jackson, what we came to conclude is that very little of that disparity is actually due to race alone or sexual identity alone. The overwhelming majority of that disparity, about 14% of that total disparity, is really due to the fact that Black sexual minority women live at this intersection of race and sexual identity. And I think it really speaks to the importance of being able to not just look at one axis of difference, which of course represents one axis of social difference, not just a person's identity, but look at multiple axes of difference to really understand what might be contributing to disparities. There are, I believe, a number of implications that come out of this work. And I think one I've already alluded to, and that is really the need to look just beyond race and look beyond just sex or sexual identity to understand barriers to care specifically for breast cancer. And we certainly saw that when we did our scoping review of the literature, that there was very little looking at just race alone, very little looking at just sexual identity alone, and there was almost really no work being done looking at issues across the breast cancer continuum, specifically for Black sexual minority women. So, a group of people living at the intersection of both being a racial minority and a sexual minority. Beyond just issues of race or sex, there are other parts of a person's identity and social positions that influence cancer-related outcomes. And it's important to understand that the disparity is more than the sum of its parts. So the women in our sample, did tend to be educated. This was both true in our qualitative data as well as our quantitative data. And so looking at also how things like socioeconomic position might influence some of these disparities is incredibly important. And again, just knowing something about what happens with Black women across the cancer continuum and what happens for sexual minority women across the cancer continuum, the breast cancer continuum, we can't just simply take those two things and put them together and assume that we understand what's happening specifically for Black sexual minority women. And one final thing that came out of our qualitative work, I think specifically, but also was reiterated by our quantitative work, is there really needs to be more training for healthcare providers to address people who are at the intersection of marginalized identities, with a special attention to supporting these constructs of autonomy, relatedness, and competence, because it does appear that when those constructs are supported, individuals are far more motivated to be able to get the screenings that they need and actually follow up with care, among all of the other factors that might go into being able to get care. And with that, I want to thank you for your attention and thank you for having me today. This is Dr. Dean's information. So my Twitter handle was at the beginning of the presentation, but if you also want to follow Dr. Dean on Twitter, you can, and learn more about our work at drdeanlab.com. And I also want to make sure that I acknowledge all of the funding that we've supported from various institutions to be able to do this work. Thank you so much for your time.